Welcome to Texas Heart Institute podcast on living legends and luminaries in cardiovascular medicine. I'm Zvonimir Krejzer, interventional cardiologist at Texas Heart Institute in Houston, Texas. We have a special guest today, and it's my special pleasure to invite today's podcast Dr. Michael Reardon.
Well, thank you for having me on. Yeah, I'm looking forward to our conversation.
Right. So, Dr. Reardon is a native of Houston and Texas, where he had almost all of his education. And there are some questions that I would like to ask Dr. Reardon that are related to his career and also development of cardiovascular medicine here in Houston. So, Dr. Reardon, you were trained in the mecca of what we call cardiovascular surgery with presence of Dr. DeBakey, Stanley Crawford, and Denton Cooley, and they all trained you in what you become, and you are truly a luminary in the field of cardiovascular medicine. Tell me, what was it like to be trained by those luminaries in this field?
Well, it really was a great honor to be trained by them. I did medical school at Baylor. I initially was going to go into internal medicine and do cardiology. But then I did my surgical rotation and decided I liked surgery. And of course, at that time, Dr. DeBakey, Dr. Cooley, Dr. Crawford were at the height of their careers. And if I was going to go into surgery, it was going to be cardiovascular surgery. So I spent my first 5 years under Michael DeBakey. Then I came next door and trained under Dr. Cooley. I was very interested in congenital heart disease, and then stayed in Houston and have spent the rest of my career here.
Very good. So what were the unique virtues of those two individuals, Dr. DeBakey and Dr. Cooley, from your training that you remember?
Well, they're very, very different individuals. Dr. DeBakey was a good surgeon, but a master organizer. As you know, he was very politically involved. He helped put together the first mobile Army units that became the MASH units. He helped turn the Navy Hospital into the Houston VA. He took Baylor from a no-name medical school to a nationally ranked medical school, but he was a little contentious sometimes. Then I moved over next door with Dr. Cooley, who was truly a surgical savant. He could operate like a magician and was a nice, kind individual. So two very different environments. I really try to pattern my career more after Dr. Cooley and the way he treated people.
Very good. So, those are my experiences as well, even though I was not directly involved in the field of cardiovascular surgery, but I did share experiences, and during my training I had similar impressions by being in presence of those two giants in cardiovascular medicine. So what was the most intimidating thing when you trained with Dr. DeBakey that you remember?
Well, I think one of the really intimidating things, and there are a number of them, was as a second-year resident, I was the resident for 51-bed cardiovascular surgical ICU 24 hours a day, 7 days a week for 2 months. There was a piece of red tape at the door, and if you were reported stepping over it, you got fired. And you were the sole care of these 51 beds. Now, the downside was it was very taxing. The upside is if you survived that, you thought you could survive anything. So that was one of the taxing experiences.
Okay. So another question is, so you trained at Baylor, mm-hmm. and then you decided to come for your cardiothoracic surgery to Texas Heart Institute, Denton Cooley. So what was the initiative or the reason to make that decision? Because you had many options available.
Well, for a couple of reasons. One reason was Dr. Cooley was really doing all the congenital heart surgery in Houston at that time, and I was very interested in congenital heart surgery, number one. And number two, I wanted to see how other people did things. I wanted to broaden my experience, and I'm glad I did. I think Dr. Cooley was the most amazing master surgeon I ever had an opportunity to work with. I tried to watch carefully. I tried to learn from Dr. Cooley, and I hope that I picked up a little bit of what he gave me.
Thank you. Just to mention briefly, you also had an opportunity to see how Dr. Stanley Crawford operates. Yeah. Can you mention in a few words what were your impressions as far as Dr. Crawford is concerned?
So I was Dr. Crawford's intern, and at that time Dr. Crawford was doing about 2/3 of the open thoracoabdominal aneurysm on the planet Earth. And one Sunday, the fellows refused to come in and help me admit people, and I admitted 19 people myself, 16 thoracoabdominal aneurysms, and 3 AAAs, all in one day. For most people, that's a lifetime experience. I got to learn it in one single day. So it was Dr. Crawford's operative schedule was really quite intense, and we were often doing 2 or 3 thoracos a day at that time.
So let's mention briefly your opinion of Dr. Cooley. You already mentioned a few things, but what were the unique features that really impressed you? Of course, you were walking with him in the hallway here of Texas Heart Institute, and making rounds and seeing patients and preparing for the procedures the next day and so on.
Well, there's a couple of things that really impressed me about Dr. Cooley. First, as I said, he was a surgical savant. I mean, he was just a genius. I would remember watching him operate and then try to replicate it. And what seemed so easy for him wasn't as easy for me. And you tried to watch and learn from him. The second thing was he treated people so well. He was kind. I remember I had a incident once where I made a hole in the undersurface of an arch, and he had to come in and fix it. The guy had multiple visiting physicians from out of the country watching him, and he wasn't very happy that I did that. But he came up later that night to my office to tell me, you know, Mike, you need to be careful around the arch as a way of saying it's okay. And I told him, for the rest of my life, I will be careful around the arch. The other thing I remember, Dr. Cooley, we'd walk on rounds and we'd go down the stairs and he'd see a piece of trash and he'd pick it up. He treated this hospital like it was his home. He was really an amazing man.
So, reading about all your professional activities, experiences, publications, and so on, you also started a research here at Texas Heart Institute that involved significantly, to a larger degree, when you went to Methodist Hospital on cardiac tumors. Can you mention a little bit about that?
So when I was a second-year resident with Dr. Cooley, we were in room 8, which was the valve room and a complex case room. And the way we did things then was, when you're ready to start, you'd start, and if you're ready to cannulate, you'd send out word that we're ready to cannulate, and word would come back either cannulate or wait for Dr. Cooley. And then if you cannulate, you'd send out we're ready, and he'd say, okay, go ahead and start it, I'm coming, or wait for me. Well, in this particular case, I sent out word, I'm ready to cannulate. Word came back, no, wait. I couldn't understand that. Dr. Cooley came in, cannulated the ACE in the aorta, the superior vena cava, and the IVC right at the diaphragm, cardioplegic the heart, cut the whole heart out, handed it to nurse, and say, keep that, I'm going to want that back. Now, he hadn't told us what he was planning on doing. We thought he was going to do a transplant. We said, where's the donor heart? He goes, no, I'm going to put that one back in. And the patient had a very large posterior left atrial pheochromocytoma. And he resected that and rebuilt the heart and put it back in. And I wrote one of my first papers about this auto transplant that Dr. Cooley had done, and it launched me on a lifelong interest in cardiac tumors and cardiac sarcoma. And in 1998, I got to do my first successful cardiac auto transplants, and since that time, we've operated on 178 primary cardiac sarcomas. We've done 58 cardiac auto transplants, and I've operated on about 458 cardiac tumors. And, you know, I talk about this a lot, and every time I do, I stop and say, I want to thank Dr. Cooley because he launched me on this path.
And you published it as well, so you are well recognized in this field, which is a truly challenging field. Now, let's move forward a little bit to another area of your interest, and you have many areas of interest. But we're going to talk a little bit about so-called endovascular interventions. You are a cardiothoracic surgeon, but you are recognized nowadays probably more than any other cardiothoracic surgeons as far as the endovascular intervention field for treatment of structural heart disease. And you participated in many, many clinical trials, particularly for aortic stenosis, but also aortic insufficiency, mitral valve disease, and more recently, tricuspid valve disease. What was the initiative? What was the reason for you to get involved into this field?
Well, I think there are really a couple of reasons. First of all, you and I were both around when we started ballooning coronary arteries.
Right.
And Brunswick actually invited the surgeons to be part of this. And they said, no, this is never going to work. We're too busy. And guess what? The surgeons were wrong. And then we come along and we start talking about putting valves, transcatheter valves, into the aortic valve. And again, surgeons said, this will never work. But some of us looked at it and said, wait a minute, this is very interesting stuff, and it may well work. And I got involved in it because I thought, A, as a very interesting research subject, and B, I wanted to make sure there were going to be some surgeons that were deeply involved, that knew how to do the procedure and could do this procedure on an equal footing with cardiologists. And that was probably going to have to be somebody senior enough to spend the time. So I got involved in this. You're right, I've had an opportunity to be the national PI in 11 trials, and right now the national chair on 4 trials. And we've done almost 3,000 TAVRs right now. And it's been a real boon, not just to my patients, but to my clinical and academic career. It's launched a lot of talks, a lot of papers. But again, it's been really a lot of fun. It's also increased our surgical aortic valve volume because it's grown our valve clinic, and as the valve clinic grew, not just the transcatheter, but the open surgical procedures grew with it. So for those of us that are looking, those of you looking for something to do, find a problem, focus on the problem, learn how to do it clinically, write about it, talk about it, your practice will grow.
So let's talk a little bit more about TAVR, a little bit more in detail. So this procedure is what, like 23 years old, and it has evolved to a significant degree. As you have mentioned, you have participated or actually being a PI or co-PI in many, many clinical trials with different products, different devices. But so what was, in your view, achieved for the last few decades? And also, what is still missing? What are what we call unmet needs at the present time as far as aortic valve is concerned?
Well, what we've achieved is we started doing this in people who were just absolutely not surgical candidates or very high risk for surgery. People that I, as a surgeon, really didn't want to operate on anyway because the risk was so high. And we found a way to do this without surgery, going up either through your chest or up through your leg and replacing your valve. And as it's gone on, as you know, this has all become all percutaneous, transfemoral for the most part. And we've done trials in all risk groups, high risk, intermediate risk, and low risk. And those trials were all positive for TAVR. And so now TAVR is available to us regardless of your risk. Now, right now, our guidelines say if you're less than 65 or going to live 20 years or more, you should still have surgery. We don't have data on younger people. So that's one of the things we're missing in some of the trials that we're looking at. We didn't originally do bicuspid valves. We've run the trials on those. So TAVR has really advanced to the point now that there's a new valve coming out. It'll be a balloon expandable valve, and it's going to go in through an 8-French expandable sheath. You as a cardiologist, who I know you've done a lot of the early endovascular work when we were putting in 24, 26 French sheaths for some of our TAVR stuff, an 8-French expandable sheath, we're almost getting down to the brachial artery. So there's some very exciting things. Mitral tricuspid, we still have a long way to go. Some of these are engineering problems, but we're making great progress there too.
And what about the tricuspid, since you already mentioned?
Yeah, so tricuspid is an interesting valve. It's always called the forgotten valve because surgeons didn't want to operate on it. It's not because the surgery was hardest, but by the time we got them, they had such a bad right heart that they wouldn't do well. What I'm hoping is now that we're getting more and more tricuspid procedures, both repair and replacement, that from our heart failure friends, we'll start seeing these patients earlier. Now, the trials so far with our repair and replacement devices have not shown a mortality benefit in the very short time they've been out there, but they show a marked quality of life improvement. And there's been some pushback about not an improvement in mortality, only quality of life, but I always remind people, every year, tens of thousands of knees are replaced. You never live longer, but you live a whole lot better. There's a lot of reasons to operate on somebody, and getting a quality of life, particularly for somebody with tricuspid regurgitation who tends to be miserable, puts them back into a useful lifespan, which most of our older patients are really looking for quality of life.
Now, you did mention that there were some challenges, and one of them, as you mentioned, was a bicuspid aortic valve. And rightfully so. Bicuspid aortic valve is a true challenge for, not necessarily for surgeon, but for endovascular interventions, because they are typically ovuloid, they're more calcified, more eccentrically calcified. They have bigger leaflets and so on, all those things. And plus, then you have aortic or aortopathy or dilatation that you have to deal with. So, in my opinion, we are still not there in finding a perfect valve that would address all those issues. Do you share that view?
Yeah, that's absolutely true. But it's really interesting. People are now looking at doing things like shockwave of these valves to break up the calcium. People are looking at lacerating the raphe so that it will expand more symmetrically. And people are even now looking at ways to endovascularly remove the leaflets and then put in a valve. Now, that sounds like science fiction now, but TAVR sounds like science fiction 25 years ago.
Yeah, I share your views. So those leaflet modifying procedures, I think, are going to be helping us tremendously in the future in doing what we call valve-in-valve, and even in native valves, whether they're surgical or any of the TAVR type of valves that would otherwise be a problem to a certain degree. Now, as far as maybe talk a little bit about, reviewing the literature, it's commonly stated that with good quality surgical SAVRs, okay? It means biological valves. You can expect about, 12-year patency and satisfactory results, and a little bit shorter with TAVR valves. What are the reasons for those things?
Well, I think there's probably a couple reasons. I mean, first of all, how long your valve is going to last is going to depend on a couple things. One of which, how old you are when you start. As you get older, you have both death as a competing risk, and the valves themselves last longer. Nobody knows exactly why, but the older you are, the longer they last. And then, valve durability is a combination of valve design and tissue science. And the tissue science and the valve design in both surgical valves and TAVR valves continues to improve. Now, one of the problems, of course, with the TAVR valves is we leave the native leaflets in there. And there's some thought from a scientific standpoint that leaving these calcified leaflets leaves an active process that will then infect the TAVR valve in some way. Whereas when we do surgery, we completely remove that, we remove all the calcium, so we put it into a clean field. Whether or not that's really true or not, I don't know. We do have some trials going out to 10 years, the NOTION trial, no difference in valve failure between TAVR valves and surgical valves, but it's a small trial. We have up to 7 years in the PARTNER trial for the SAPIEN 3 valve. In 7 years, there's no real difference in reintervention. In 5 years, there is no difference in reintervention in the Evolut low-risk trial. I'll be presenting the 6-year data at CRT next month. Can't talk about it yet.
Okay, so now, as a cardiothoracic surgeon, obviously you have a choice whether to recommend a TAVR or SAVR or mechanical valve. What is your thinking process when you talk to the patient?
So I really try to ask myself, how long is this patient going to live? Because for the life management of aortic stenosis, I'd like to get you through your life with either no surgeries or a maximum of one surgery. And so I ask several things. First of all, if you're going to live less than 20 years, then you're probably just going to get 2 procedures. If you're going to live less than 10 years, you're just going to get 1 procedure. TAVR sounds great. The Sweetheart database in Sweden, which is a very complete database, looked at their isolated aortic valve procedures, and they divided them into high risk, intermediate risk, and low risk, and they looked at the mean survival. In high risk and intermediate risk, only intermediate risk kind of bumped up against 10-year mean survival, and only low risk went above that. Well, we have pretty good data that these valves are likely to last 10 years, so if you're higher intermediate risk, TAVR seems pretty good. If you're low risk, then it becomes a little bit different. If you're going to live 20 years or more, we have to start thinking about that. Now, you and I can look at the CT scan. If the coronaries are high and the sinuses are big, I can probably put 2 TAVRs in there. If the coronaries are low and the sinuses are low, I may not be able to do more than 1 TAVR and then have to explant that TAVR into a surgical valve. I still look at, if you're less than 65, I typically will recommend surgery for you unless there's extenuating circumstances. I had a man not too long ago, 63, bad aortic stenosis. His wife was diagnosed with glioblastoma. She's given 9 months to live. He was so debilitated he couldn't care for. All he wanted was a TAVR to care for his wife. He knew he was going to get surgery likely one day. But most of the time, I try to follow the guidelines.
One really intriguing thing as far as managing patients with failed TAVRs when you have to intervene surgically, what are the challenges that you have encountered? Yeah. And what is the mortality of removing the TAVR valve versus, let's say, doing a surgical valve procedure on a native virgin valve?
Well, the challenge, of course, depends on the valve. If you're using a balloon expanded valve, the valve looks kind of like a surgical valve. You just have to crush it and get it out. With the self-expanding, if surgeons aren't used to nitinol, they don't understand when they pull it away from the wall, it goes back and gets in the way. Now, we've developed ways to fix that. The key is you can't just pull it out. You always have to move to the middle, like doing an endarterectomy. And there have been more root replacements with these than just doing surgical aortic valve replacements. We did a big study called Explant TAVR that we were part of, and the mortality was quite high. It was about 15%. But if you look at the mean number of TAVR explants done by most surgeons, it was 1. They didn't have any experience. Now, as we gain experience, the risk has gone down. Are actually getting ready to look at we've actually looked at ours. It's going out for publication, so I can't go over all the data. What I'll tell you is that the first half of our patients, the mortality was 17%. The second half of our patients, the mortality was 4.5%. And it's probably a combination of less risk patients and us learning how to do the procedure. It's going to be the fastest growing procedure for young heart surgeons to learn how to do, because we can't put a TAVR in everybody because of coronary issues, mismatch issues, etc. But right now there is an increased risk.
Excellent. So I have one question that is very close to your area expertise and the volume of patients that you have performed TAVR procedure on. Let's talk a little bit about self-expanding versus balloon expanding valves. What are the advantages, disadvantages of each, and when you choose one versus the other?
Sure. Well, the advantage of a balloon expandable valve is it's really quick, it's really easy, and it's very, very reproducible. It's a short frame, so it's easier to get back in the coronaries, and the pacemaker rate is closer to that of the surgical valve. The self-expanding valve, the advantage of self-expanding valves has been that they've had better hemodynamics, but they're all long frames right now, so they go above the coronaries, which can be a challenge for a cardiologist to get back in there. It can be a challenge for the second valve to go in there, and the pacemaker rate has been higher in self-expanding valves. Now, there are some new balloon expandable valves coming out that seem to have hemodynamics that match that of self-expanding valves, and right now the market share in the U.S. is the balloon expandable valve because it's quick and it's easy. It's very reproducible. And most cardiologists out there and surgeons that are doing this are worried about how are they going to do with this admission this year. They're not worried about 10 years down the road, which is where hemodynamics come into play. As I said, there's some new balloon expandable valves coming out that I think are going to be very interesting. They're using new materials in the frame, rhenium, which is further down the periodic table. It's stronger. You can make it thinner. It no longer is a stent made with diamonds because diamond stents always shorten as you expand them. These are just open cells with rigid bars, so it doesn't shorten at all. I think for my interventional colleagues, the next 10 years, they're going to see vast improvements. And the only thing that are keeping us from going to younger patients is long-term durability data in younger folks. And we're starting to generate that now.
So the evolution continues. There's no doubt
Absolutely.
about it. But being a surgeon, you know the anatomy real well. With TAVR valves, the way they exist at the present time, it's truly a primitive way to correct the problem because, I mean, the nature provides us with coronary sinuses, perfect washout, perfect circulation in the coronary arteries, and also no gradients across the valve. So we do have challenges in meeting that goal in the future.
Yeah, but again, as I said, my open isolated surgical valve replacement has gone up 20% in the last 4 years because of the increase through our valve clinic and the fact that we have a real heart team making decisions we feel are best for the patients, not just easiest for us. That said, transcatheter work continues to improve. We may eventually be excising these leaflets and putting in a valve, all through your leg or through your arm. That's a decade down the road. But again, the advances that you and I have seen in the last 2 decades were inconceivable when we started.
Excellent. I have one final question, and this is, what would you like to achieve for the next several years or whatever length of time is left in your professional career that you have not done so far? And I know that you have done many things. You were involved in vascular field with stent grafts and malignancies, cardiac malignancies, structural heart, and so on. What else would you like to achieve?
Well, I've been very, very blessed in my career. I mean, to work with Mike DeBakey, Stanley Crawford, Denton Cooley, there's a handful of people that can say that. I've worked in Houston. I've been at my institution for over 40 years. I've had a chance to do a lot of things. I've traveled. I've been an invited surgeon on 5 of the 7 continents. I've spoken on all those continents. I'm less worried about what I'm going to personally achieve than what I'm going to leave behind. I look at my job now as program building and career building, and what I'm trying to do is set my department of cardiovascular surgery on a pathway that when I leave for the next generation, they're set to move forward, and that my faculty can start taking over some of the national level jobs that I've had the privilege to run. As you know, those jobs are highly sought after. I want to use my influence to help my folks get in those positions. Well,
Dr. Reardon, it's a special pleasure to have you here and a privilege to be my friend and to know you for decades. Thank you very much
thank you for
being
having
here.
me here.
Yeah.
The pleasure is mine.
We're at Texas Heart Institute, what we call a Wall of Fame, with all the cardiothoracic surgeons that trained by Dr. Cooley here at Texas Heart Institute. And here is Dr. Michael Reardon, who trained here as well. Michael, so what goes through your mind when you start thinking about the past times when you trained here with Dr. Cooley?
Well, it brings back some very good memories of working with Dr. Cooley and the team here. And you know, Dr. Cooley worked so hard to help so many people with his individual skills. But when you look at the people he trained, you realize he's trained enough to not just help certain patients, he changed the world. It's amazing to see what all he's done.
Dr. Reardon, I found your photo here from 1985. You trained here from 1983 to 1985 at Texas Heart Institute.
Well, thank you. It's really, I look at myself and I think I was a child when I was here, so long ago. And I see Greg Kay, who trained with me, Michael Sweeney, who trained with me, Bill Powell, Michael Carmichael, and John McDermott, who were here the year before me and were my senior residents. And then I move over to John Garrett, Bill Johnson, and Peter Murphy, who were the year after me. But look across this entire wall, the number of people that Dr. Cooley has trained and the good they've done for the world is incomprehensible.